When it comes to spine surgery, challenging the status quo can change lives. In this candid conversation, retired surgeon Dr. Steven Sobol and Dr. Jason Cuellar explore multi-level disc replacement, breaking old rules to deliver lasting results.
Okay, I'm here in Park City, Utah with Dr. Sobol, a retired, successful head and neck surgeon. And I met you through Dr. Adelman. Can you tell me how you know Dr. Adelman?
So I know Dr. Adelman for many years now, and I've observed this practice. I've even had him operate on me. Being a retired head and neck surgeon and someone who does what you call physician navigation of healthcare, that have spine problems and are looking for answers. In 2019, I was experiencing what I thought was a back problem with ridiculous symptoms down the front of my thigh and toward my knee. The MRIs that I obtained were misread. The long and the short is I got a hold of Scott and I said, I don't know why I didn't ask you sooner. Do me a favor, review my MRI and talk to me. And he said, look, you've got a L4-5 right side, no question. It'll be proven on the MRI. Let me see the MRI. And there it was on the MRI, and my nerve was squished by the disc that had herniated. And I had been through, we tried the usual transforaminal epidural shots and what have you, and I wasn't getting relief. It ruined my season. Couldn't sit in the golf cart because it was too uncomfortable. I had to ride on the back of the golf cart. I couldn't stand over a putt and bend over because of the discomfort in my leg. The procedure took 17 minutes for Scott to do an endoscopic procedure to remove the disc. I got up from surgery and I walked out and I never had pain since. His biggest concern that I would return to too much vigorous activity too soon, which because of my impatience I tended to do, but nonetheless, I've never had the problem again. In 2019, that got my interest up. So I went to the operating room with Scott and I watched him do several surgical procedures, and I began to brush up on spine because I wanted to be informationally correct with patients who would call me and say, what do I do? I've seen this person or that person, what have you. Your name came up as these years moved on in a serious way, specifically regarding disc replacements in the lumbar spine. And I've had a number of patients who have situations which clearly lend themselves to this, one of whom you just interviewed, John Rubenstein. Now, John and I have been best friends for 10 years, and he was frustrated. His back was shot. He couldn't play 2 rounds of golf in a week for anything in the world. He couldn't do it. And he's an athlete, as you know. He's built like a brick, and he's in great shape. And he was frustrated beyond belief. And Scott had met with him many, many times because of Scott's own problems and suggested that he see you. And he's from Florida, so this was easy. Because of the way in which things are structured relative to insurance and private pay and how it's all done, he was very reticent and he wasn't getting the answers he wanted. And he couldn't get them to go past one level. Would you do 3? If someone else approved 3, he says 1 and only 1. And it's pioneers like yourself who I hope are going to change the paradigm of thinking. And it's going to take time and probably a multi-institutional support process or a multi-surgical support process. People with deep experience willing to put their data on the line and show that multi-levels are appropriate and safe.
Well, we actually have the data. You know, Sentinel Spine actually pushed through the 2-level data, for example, that was done over 10 years ago. So they finally submitted that to the FDA, I don't know, 4 or 5 years ago, and we're able to get the 2-level lumbar ADRs approved, right? You know, they should have done that to begin with. I don't know why they didn't do that earlier, but now we have 2 levels approved. We've published our data on 3 and 4 levels and you're showing long-term outcome and long-term motion preservation. What gets me the most is, you know, a lot of the surgeons telling patients that they can't have disc replacement for reason XYZ,
Yep.
and I see they're just not true. And the other thing I see, which is I think really problematic, is even from, you know, my own training, I was trained you shouldn't even do surgery on someone for back pain, and spine surgery can't help low back pain. Well, we just saw,
the proof's in the pudding.
You know, your colleagues and friends now who have had 3-level lumbar disc replacement for back pain, and their back pain is gone. They're running triathlons and golfing.
Now, one of the reasons that it's possible John was turned down is he's 59 going on 60, and there's this magic cutoff that in the literature of 60 that we wouldn't do these disc replacements over the age of 60? And the answer is, why? What's the clear-cut reason for that?
There's no good reason.
There's no good reason.
You know, I've done lumbar disc replacements in 80-year-olds. And to be able to reduce the burden of fusion, because I've seen an 80-year-old have a multi-level fusion and that turn into a bad situation. They've had to have a T10 pelvis fusion after that. I mean, and they're just not functional after that.
The question is, what's it gonna take for the paradigm to change?
Fortunately, answers that most of us don't want to hear, and the answers to a lot of things in the world, and one of them is money, unfortunately. And you know, it comes down to, for the access surgeon and the insurance companies reimbursing these cases. So the insurance companies have control over a lot of what a lot of surgeons do, right? You know, they're running around saying, you can't do 2 levels, you can't do 3 levels, you can't do it in someone over 60, you can't do it in someone that's had a previous microdiscectomy.
Or multifacet disease.
Yeah, exactly. And we're proving that that's not correct either. So I think we just have to keep publishing our data and keep educating not just surgeons but patients. And I'm really taking the view that this is a patient-driven
It's a great
change,
view.
because I'm not getting very far with trying to change insurance companies' minds at this point. And I think that patients have to be educated and understand that there is an alternative to fusion.
What are your thoughts on TOPS as an alternative to fusion?
You know, it's an interesting device. I think for certain people, certain situations, I think it may be very useful. There is some longer-term data that we have in Europe. We don't have the long-term data here in the US, but we'll have it at some point. So I'm in a little bit of a wait-and-see pattern, but I do think that for certain patients, I would use it.
How often do you find yourself doing a hybrid procedure where you're doing a disc replacement and adjacent fusion?
Well, for example, you know, I had a patient who was actually pretty young, but she had a facet fracture at L5S1 from a trauma, and she had adjacent L4-5 disc degeneration. So that's a hybrid situations. A patient that has, you know, I recently did a gentleman out from the Midwest, a farmer with bilateral L5 pars fractures and a steep sacral slope and pretty bad disc degeneration at L4-5 and L3-4. So I did a 2-level disc replacement above a fusion at L5S1. So those situations are actually pretty common. You know, L5S1, we say that it's the easiest level to access, but the hardest level to do for arthroplasty.
Yes, for sure.
It's the highest risk. I'm Dr. Adelman. You know, his case turned out perfectly, and so did John Rubenstein. You know, their L5S1s were amenable to artificial disc replacement, but some people are not.
So someone's got foraminal disease with some compression, a little disc herniation. They've got some radicular symptomatology, but they also clearly have disc degenerative disease in the disc itself. They need a disc replacement. Will the disc replacement open up the foramen enough that they don't need anything done at the foramen?
It sounds like you're asking it from a surgeon perspective more than a patient perspective, because you clearly understand more than the average patient. So that is a very complicated but yet common situation. So that's why I really have to spend a lot of time with the patient and say, look, how much back pain do you have versus how much leg pain do you have, right? If it's someone that just has leg pain, no back pain, right, like you, right?
Right.
And they have purely foraminal stenosis from disc herniation or bone spur, I'm going to recommend a foraminotomy first. There's a chance that if the disc is collapsed or collapses more, that you get what's called vertical stenosis.
Right.
So I can do a perfect foraminotomy, but I like to say sometimes I need to raise the roof because the roof is falling and hitting the floor, right? So there's not enough space for the nerve. So that in that situation with no back pain, I say, okay, look, we're going to do this decompression first, or I'm going to send them to Dr. Adelman to do endoscopic decompression, right?
Sure.
And if the decompression is done perfectly, and their nerve pain doesn't go away, or maybe goes away for a little while. And sometimes it happens, it goes away for a year, 2 years, 5 years, right? And the disc collapses more, the radiculopathy comes back. That's my case, actually. I just met you, so you don't know. I have a lumbar disc replacement in me.
Oh, I see.
That I've had for 6 years. I didn't get mine for back pain, I got mine for radiculopathy. When I was 20, I had a disc herniation, kind of foraminal paramedian, had a microdiscectomy for radiculopathy. Radiculopathy got better for 6 months, came back. I lived with it for 15 years.
No fun.
Static pain for 15 years. It really affected my life. When it got to the point where I couldn't get up and walk it off, I had leg pain standing up as well. I said, look, my disc is gone. I'm bone on bone because that microdiscectomy.
So you were that narrow already?
Oh yeah, well, because I had a microdiscectomy done 15 years before, so the disc was taken out.
There wasn't much disc anyway.
There wasn't any disc left anymore. Right, so my nerve was being smashed vertically. The only thing that would have worked would have been a fusion or a disc replacement.
Sure.
Right, so obviously.
Well, lucky we're able to still have a disc replacement given the size that you had left.
Well, luckily I had a excellent partner, Dr. Todd Lamb in Los Angeles, who trained me how to do disc replacements.
Oh, I see.
And he's a master at that. And so he was able to restore my height, put in the disc replacement, and
make you a little taller while he was at it.
Make me a little taller, get me back to my original height, and my leg pain was gone.
What do you see as the need for improvement in the disc replacements we're using now? What do you like to see improved upon the actual implant? Or have we reached the point where not much improvement is needed?
It's interesting as we go through different iterations, and I have these patients coming to me from Europe who have had the next generation ESP or M6, or there's a Maverick there now, and for a while we had the Activell here. I now believe that the old Pro Disc, the original Pro Disc, is the best disc on the market. There's really no flaws with it. The only things I would change were to add a few more sizes for the really big patient or the really small patient, and they are working on that. And the other thing is, if we could make it out of titanium and less cobalt chrome, we could get a better MRI post-op. That's really all I would change. Other than that, the implant is pretty amazing.
Well, it's been a pleasure meeting you, and
likewise, great chat.
It's been a lot of fun.